Okay, all right. So away we go. Again, I'd like to thank Philips for their sponsorship of the Coaching Corner. They've been great partners in providing support and sponsorship for this section. We're going to talk about lumps and bumps. So in my experience, I have seen emergency docs who either love the odd lump or bump and the pus thing that might ooze, or they run the other way. I don't know which category you might all fit into, but when we're looking at lumps or bumps, they can either come because it's all of a sudden urgent at 10 o'clock at night and it's bothering them. The lumps and bumps might be in a really awkward spot that it's starting to cause some pain, or it might mean that there's some infection. And so before you get your scalpel out, you need to make sure that everything is hunky-dory and that you're not going to put a scalpel or a needle into something that's very vascular and that could be quite risky. So the goals of ultrasound when we're looking at lumps and bumps is to determine where the location is, if you can find a bony landmark or something, so that you've got a reference point. We need to look at the relationship of the lump to surrounding structures. Is it going to be right next to an artery or something, so that when you do go to put a needle or a knife in there, that you don't accidentally go through an artery first? What's the size? So we want to measure the lump or bump in 2 planes to get an idea of the size. Look at the sonographic characteristics. So are we looking at something that's solid, liquid, somewhere in between? Is it compressible or mobile? And is there any blood flow or vascularity associated with that lump? The equipment you're going to use is invariably the linear probe. If you have a hockey stick, the closer something is to the surface, the higher the frequency probe you should use. So if it's quite a big lump, for example, an abscess on a buttock or something, you may even need to use the curve probe to get the field of view and the depth penetration. It depends on your patient. But most of the time you're looking at a linear probe, and the closer this lump or bump is to the surface, the higher the frequency. The hockey stick can come in handy because it's just got such a nice little footprint and it makes it nice and easy to maneuver. When we look at how we're going to approach this from an ultrasound point of view, we want to look at the area of interest, but also compare that area of interest with the unaffected side. Most of the time you have a normal unaffected side and an abnormal, or the side that's presenting as being sore. So if you look at the anatomy on the other side to compare it with, you get an idea of what you should be expecting to see, and then it makes you more confident of what you are actually seeing. We want to image in both the long and short axis plane. For some lumps and bumps, particularly on fingers and hands and stuff, you may be able to use a water bath or a standoff to get your probe a little bit away. The problem with the high frequency probes is they're really good for giving us good detail, but sometimes in that very near field, in the first sort of ½ centimetre, we lose resolution because it's kind of in the dead zone of the probe. So if you can either put a big blob of gel or use some standoff technique, whether it be a glove or whatever, and we'll have a look in a moment at some of those, that can help you just get a little bit further away to get a little bit more detail at the skin surface. We want to be mindful of how much probe pressure we're putting on, because if you've got, for example, an abscess or a little fluid collection and you put too much probe pressure on, you can actually squish it and make it disperse. So you need to sort of balance your probe right on the gel rather than plonking it on the skin. And as I said, lastly, look for the vascularity. Another top tip here is to make sure that your hand and up to your elbow, as much as you can, support your forearm. What that lets you do is just be really light with your probe and allows you to balance the probe on the gel. If you're sort of standing up and leaning down or whatever, you can tend to put more pressure on than you need to. And in some circumstances, it's going to make it very difficult for superficial sort of lumps and bumps. So some of the ideas for standoffs, you can have a big blob of gel, as we can see there, if you've got that really thick gel. You can actually buy standoff pads, and the Aquaflex, they're like it's almost like a gelatin sort of soft, gooey, sloppy thing that you put on the probe. And if you don't keep them nice and moist, they will dry out. As I found out, we discovered some at our place the other day that are a bit old and they're completely useless. But when they're fresh and new, they're quite like a really firm jelly. And so you can put a little bit of gel on the skin, pop the standoff on, and then gel on the top, and then that gives you a good standoff and allows you to see the skin surface better. If you haven't got anything, you can improvise, use a glove full of water. Be careful when you tie the knot in the glove where the air bubble goes. You can even use like a saline pack, you know, like the little 50 ml saline packs. And again, just be careful where the air bubble is, that you're not scanning over the air bubble. Or you can use the hand in the water bath technique, which means your probe doesn't actually have to touch the skin. So if someone's got something really that's quite tender, this is a really good technique because it means that you don't actually have to put the probe on the skin at all. And potentially if there's something there that's an infection risk. It's a little bit closer up. If we look at that gel as a standoff probe, you can see up here, it allows you to see the really nice skin surface because we've got a bit of gel that's getting us away from the edge a little. You can see here, now when you prepare a water bath, it's useful to kind of think about not having the tap running full bore so that it's nice and aerated. A lot of our taps, especially in Australia where we're trying to conserve water all the time, have like something in the tap head that means that they shoot out water and it's quite aerated. And so what will happen is you'll get a lot of little micro air bubbles in the water. So either let it run really slow so that it just dribbles in to fill up, or you need to put the water in the water bath and let it sit for a little while before you'll be able to scan, because if you have a lot of little air bubbles, it's going to interfere with the picture and create reverberation. And you can see on the images here, the water is a really good medium for transmitting sound. So it gives us incredible detail right around the skin edge. And you can see on this one, we've got a foreign body here. And again, over here, it's allowing us to see digital arteries and digital veins, which if we had our probe actually sitting on the skin surface, the weight of the probe would actually compress those vessels. So it allows us to get really clear pictures. Now the other big trick here is to compare sides. You have a normal to compare against. So have a look at the normal side, you know, what's the thickness of the skin, what's the echogenicity of the tissue, and compare all those things when you're looking for your lump. And also be mindful of your depth settings. If you're looking for a deep abscess, you need to make sure you've got your depth set quite deep. But if we're just looking superficially, we want to make sure that we're using the best area of the probe and that we've got our focal zone set correctly. So on a lot of machines, the depth setting is really crucial for the focus because you can't control it. So they have automated focus on a lot of machines. So if you set your depth too deep, then your focal zone is going to be at the wrong area. So be mindful to optimize your depth settings for where you need to look at. We're aiming to put our target sort of at that 50 to 75% of the way down. Now, if we look at the sonographic anatomy, we can see the skin surface here. We have this darker area here that's the subcutaneous tissue. And obviously the thickness of the subcutaneous tissue, depending on where you're looking and how what your patient's body habitus is, what that subcutaneous tissue will look like. Then you can see the striations here of the muscle. This bright white line is the superficial muscle fascia. And then down here we have the bone. And if we get that right at 90 degrees, you can see the shadowing. So I'm just going to take you through a quick tiki tour, if you like, of some lumps and bumps and show you some pictures. It's not uncommon for patients to present with lumps and bumps, and it can be anything from ganglions to a hematoma to lipomas to infection. It really is important to have a good understanding of the clinical history to correlate that with what you're finding. So let's start with some ganglions. These are non-malignant cystic masses that occur in association with either joint spaces or the tendons. They're most commonly seen in the hand and wrist. They can occur in post-traumatic or post-surgical situation. So when we look at the ultrasound of these lumps and bumps, they're often hypoechoic or anechoic and filled with fluid. They usually, if you track these, you can see some communication with either the joint or the tendon sheath. They're well defined, smooth walled. Because they're a cystic structure, there should be good through transmission or posterior acoustic enhancement. Sometimes they can be quite irregular in their outline, it depends. And if you have one that's ruptured, you may have some internal echoes within it. A Baker's cyst is a good one behind the knee. This one, you know, pronounced lump or swelling at the back of the knee, more obvious when they're standing. You know, often we just find these as an incidental finding when we're looking for a DVT. But you see a cystic space that sits between the medial gastrocnemius and the semimembranosus tendon. So it looks kind of like the ganglions do, except for their location is behind the knee. And you'll often see this sort of speech bubble appearance or a comma. And that this comma bit is the bit where it is communicating with the joint space in between the semimembranosus and gastrocnemius muscle there. Here's an example of a ruptured Baker's cyst. So you can see that there's some internal echoes. Now, the differential here also could be a popliteal aneurysm. So it's really important to pop the colour on and determine if there's any colour flow. If there's colour flow in it, that's not a Baker's cyst, it might be a popliteal aneurysm. So don't forget to use the colour to help you distinguish what this might be. You can, patients presenting with like sebaceous cysts or big lumps, often on the hairline and can be anywhere really. But as you can see on this picture here, this one you can see the sort of punctum. If you are scanning and not putting too much pressure on, you can actually see that punctum sometimes on the ultrasound as well. So we can see this one here, well circumscribed, predominantly hypoechoic. They're usually ovoid or spherical. Sometimes they can even be a bit lobulated or tubular. The larger lesions can sometimes be a little bit heterogeneous because there's mucoid fat, calcification, pus, depends on what's in it. But you can see here almost where the punctum comes up to the skin surface. Here's some more examples of a sebaceous cyst. So a well circumscribed mass. Occasionally I've seen a couple of these where, and this one could maybe be one where there's an ingrown hair, and so you see like a little stranding in it where the ingrown hair has sort of coiled around on itself. So be mindful, especially if it's along the hairline, that you can look out for those sorts of signs as well. Haematomas. So
I was just going to say the worst sebaceous cyst I've seen was in an interesting spot, which was over the sternum, was pretty much in the midline.
Yeah.
But it was massive. Seriously, it would have been.
Oh, you just
and the guy was large. The guy was large. So it probably would have been grapefruit size. And but unfortunately, he was a bit of a non-compliant person, and he didn't want to. And at Wonthaggi, we clearly couldn't deal with it. And it actually was that big that there was worry that it could have been involving the sternal bone and have osteomyelitis with it, because it was that big that it could have invaded the bone. He was a little bit unwell, but not terribly so. And unfortunately, he discharged himself, even though we and his friend tried to talk him into staying because he didn't want to be transferred to a larger hospital and we couldn't look after him. But yeah, I mean, the biggest one I've seen was in a really odd spot over the sternum. We were pretty confident it was actually, you know, not arising from the bone itself. It was soft, and when I scanned it, it certainly wasn't bony consistency. It certainly looked like those pictures of a sebaceous cyst.
Well, and then I think the really important thing then is just turning on the colour to make sure it's not something else that's nasty, you know, like a liposarcoma or something like that.
Yeah, I don't think it mattered with this guy. What I told him was he wasn't going to stay, but yeah, you're totally right. You want to make sure that, you know, you're differentiating something with flow with something that doesn't have flow. Big difference, isn't there?
Begs the question of why you came to hospital in the first place, but anyway.
I'm sure everyone else on the call can tell you people who come to the hospital because they want to hear what they want to hear, and when we tell them it's something else or that they have to get transferred, then they leave, and that's not that uncommon, unfortunately.
Gosh. gosh, there's a whole channel on YouTube. I don't know if any of you have heard of the pimple popper that has got the most, I don't know how people let these things get that big. But anyway, they finally get them seen to, I guess, when they start to either rub, get sore, or start to look wrong.
Yeah, or someone else
anyway.
Notices and tells them to come to hospital.
Yeah, that's it. In your patients with trauma, you know, a ball in the leg or kicked in the leg or anything, they might have post-surgical. So I mean, it really depends on the patient's history. But a similar looking mass here, or similar looking lump in this case, because of the history, is a hematoma. So the hematomas, localized collection of blood, form virtually anywhere, usually in response to something. But they can have internal echoes, and it depends on how old the blood is. So when blood is quite fresh, it'll be quite liquid and so will show up as black. But as that blood coagulates and clots up, then it starts to get internal echoes. And then after a period of sort of 24, 48 hours, it starts to undergo lysis again, so it looks more liquid. So it depends when you catch a hematoma, what it can look like. But they can be, you know, reasonably well circumscribed and will correspond to the local area of pain.
Most of those ones, Suean, that I've seen have been on the lower limbs, and I think, you know, certainly in our Wonthaggi population, which is very old, unfortunately, half of the population is on anticoagulation. And so it seems to take like virtually no trauma for them to get a hematoma. Have you ever seen one? I've seen one that actually had calcification in it. It had been there for that long.
Yeah, what is it, osteo?
Sort of like that ossificans sort of phenomenon.
Ossificans, yeah, that one. There's an M in that word somewhere.
Myositis ossificans.
That's the one. That's the one. I've seen a couple like that. Yeah.
Yeah.
And it almost looks like you get like calcification and then the associated shadowing with it. But again, it's understanding what the history is of that lump to help you sort out what it might be. Lymph nodes are another one that can pop up from time to time. You might see lymph nodes as part of a normal procedure, like if you're scanning the groin to do a femoral nerve block or put in a catheter, or even in the neck, you might commonly see lymph nodes in these places. Normal lymph nodes are sort of kidney beaned or oval shaped. They have a central echogenic hilum. They're mostly hypoechoic. There's a few different ways that you can differentiate a normal lymph node from an abnormal lymph node, but there's no one single criteria that says, you know, this one's normal, that one's abnormal. You need to look at quite a few things all together. Here's another example of a normal lymph node. So you have a hypoechoic oval, well circumscribed sort of lesion here with an echogenic hilum that's continuous with the adjacent soft tissue. Normal lymph nodes, typically, if you put the colour on, you don't see a whole lot of colour. You can, if you put the power Doppler on, you may see a tiny bit of central colour flow or blood flow in the hilum of the lymph node. But there's a difference between just a little bit of colour and when it starts to look quite reactive here. So, you know, the more colourful, the easier that you see that colour, the more it looks like almost like a tree. So you have that central hilum and then branches radially towards the periphery of the lymph node. So that indicates an inflamed lymph node. So when it's quite organised and looking like a tree, that's a reactive lymph node or an inflamed lymph node, versus when that colour flow is just really irregular and random, and that's probably more associated with a malignant lymph node. So here's an example of a malignant lymph node in a patient with a known lung carcinoma. So he was proven to have metastatic lymph nodes in the lower cervical and supraclavicular regions. What we're also looking for here, you can see now that this lymph node looks quite round rather than that ovoid shape. And I don't have colour with this one, but we're also looking to see what the colour flow pattern is. You can see on some of these ones where it's really disorganised around the periphery and you lose that kind of tree shape to it. Now, the role of ultrasound in lymph nodes, from a point of care perspective, it's just to recognise that there's a lymph node or not. If there's anything you're worried about, you'd refer it on. When we're looking from a radiology point of view, we're trying to characterise, to take a sample of to do further investigations. But you can see on these abnormal, it's quite round, it's starting to get quite deep. We can see really disorganised flow around the periphery. The problem with the colour flow here is that you need to know how to use colour well. You need to be able to set your colour gain settings so that this isn't just the flash artifact that you see when you move the probe. So it does require quite a bit of skill to be able to get your machine settings just right so that you can actually demonstrate this. So not necessarily a point of care application, but handy to look at these nodes and know that that's what that lump is and it needs further investigation. So the normal lymph nodes are hypoechoic with an echogenic hilum. They're generally more flat or oval shaped, kidney bean shape if you like, and you don't see a whole lot of colour centrally. Reactive lymph nodes are increased in size. They have the same characteristics, echogenic hilum, but you see that increased vascularity in a tree-like pattern. And malignant lymph nodes are hypoechoic and you lose the echogenic hilum. They're much more rounder in shape. They can have an irregular pattern of vascularity and sometimes they can even look a little bit lobulated. So we move on to some lipomas.
I was just saying, so the other reason to do... So I was just saying the other reason to do ultrasound when you think it's a lymph node that's enlarged is sometimes, you know, you're checking as to whether there's an abscess within the lymph node itself, which can happen because that would usually require surgical drainage. So the ultrasound is obviously very useful in that because you're going to see an anechoic area within the lymph node with, you know, posterior acoustic enhancement. There's not going to be any flow in that area. So it's obviously, it's a similar, you know, as you're probably going to get on and talk about abscess and cellulitis, but it's a similar thing to that. Is clinically it can be very difficult to tell with those enlarged lymph nodes which one's got an abscess in it and which one doesn't.
So we'll move on to lipomas. These can be soft variable echogenic masses, usually encapsulated, but they can sometimes be really, really difficult to see on ultrasound because it blends into the surrounding fat. And so you'll be able to feel where it is. And, you know, if you squint your eyes, you'll sort of start to see the boundaries, but sometimes they just blend into the fat. So I've included this picture here. This is sort of normal fatty tissue or a fatty layer here. When we have a lymph node, you can see that sort of stranding that happens in normal fatty tissue. This one is nicely circumscribed, and this is on, you know, radiology machine where we can use like an extended field of view. So it's quite large, 7 centimeters. You kind of mark it out with your fingers and then figure out where the ends are, really. We've got lots of different ones here. They can be variably echogenic, but they really blend into the surrounding fat tissue. And sometimes they can be quite difficult to see. So we can see this one here that's quite well, so you can see the outside border around here. The difference between, again, with a lipoma, pop the colour on, there shouldn't be any blood flow within it. If you have a lipoma or a mass like that and you put the colour on and there's blood flow in it, not only do you not want to be putting needles and things in, but you probably don't want to be putting a knife in either. But, you know, liposarcomas look like a lipoma, except they have colour flow. So you can see here really irregular peripheral flow here. This one's got a lot of flow in it as well. This is quite hypoechoic and well circumscribed, and this is the zoomed up picture of that one. And then, you know, patients present with really red inflamed areas, and the question is this just cellulitis or is there an abscess? So if we think of cellulitis, they get that classical sort of cobblestone appearance, and you can see why it's called cobblestone appearance with this picture. Lots more examples. So when the tissue, like if there is infection in the tissue, the first port of call here is that the superficial tissue compared to the non-affected side will at first be a little bit brighter. So it gets a lot of the muck comes in, the infection response comes in, and it causes the tissue to be a little bit bright first before that fluid is then pushed in between the bits of fat, and then you get this cobblestoning. So look at the non-affected side. The first sign of it might be that the tissue is just more echogenic. And if you use the dual function on your machine, that you can do the non-affected side right beside the affected side, that will help you to be able to demonstrate this. You can see it's got a real classic appearance of that cobblestoning with the fluid sort of forced in between the tissue here. As we go down this leg, we can see that there's quite a large area here of cellulitis. Whereas an abscess has the appearances of an abscess can be quite variable. It depends, you know, where you're catching it, how much fluid's within it. They can range from anechoic to irregularly hyperechoic. There may be internal echoes, there may be hyperechoic sediment or septae, and you can sometimes even get gas in it, depending on what bugs it is. They range from being quite round and well-defined to completely irregular and lobulated. Often you'll have posterior acoustic enhancement, and that might be your only finding, and that's because the sound travels through the fluid quite easily and we get that acoustic enhancement behind it. In this instance, you should also just do the test or squish it a little bit to see if you can get like a pus stelsis, and that's the ability for us, as we push on it, you can sort of displace the pus inside and you'll see the swirling of the pus. So you're inducing motion in the material within the abscess. Here's an abscess, you can see, is well sort of circumscribed as a mass, versus cellulitis being that cobblestoning appearance there where the fluid is pushed in between the tissue. Oops, didn't want to play. Let me just play it here. So you can see this one's got a number of little areas in it, and if you were going to drain that, you probably have to put your needle into a couple of different spots to be able to drain it. And you can see they're well circumscribed. If you push on that, you see the swirling of that particulate material inside the abscess. Here's a abscess that was on the backside, a perirectal abscess. It's quite big. And you can see there's a lot of sort of tissue and there's septations, and essentially you're just marking where the upper boundary is and the lower boundary. And sometimes if they're really big, you've just got to measure it on the skin rather than be able to use the ultrasound to measure it. The ultrasound, I guess, then confirms that it's there, and also what is it? Is it really liquid that it looks like it will drain easy, or is it really solid with lots of material in it that it doesn't look like it's going to drain and might need surgical debridement? So we've got another abscess here. So you can see the posterior acoustic enhancement on this one quite nicely, and there's quite a lot of rubbish in the middle here. I'm not sure how easily it will drain. And of course, you can also get necrotizing fasciitis. Now, the difference with this one is that you'll get subcutaneous tissue thickening. So look at the skin in particular, so compare with the non-affected side. And the other telltale sign here is the subcutaneous air. So you can see these bright echogenic bits here. They're air with sort of dirty shadowing behind it. Use a play. No, it doesn't want to play. So you can see the dirty shadowing and the streakiness sort of from behind that area of necrotizing fasciitis. Now, what do you reckon about this one? It could look like could be cellulitis, or it could in fact be an abscess. But in this case, we can see the tendon here, and we can see the joint space. And this one is actually a septic joint. You can see that this area of hypoechoic is continuous with the joint space there. So it's important to figure out, is it a well-contained collection that's sitting separate from the joint, or is it in this one, it's not a cellulitis or an abscess, it's actually a septic joint. Now, the other thing that we mentioned was you can sometimes get lumps on the face, either submandibular gland or parotid gland. So it's kind of understanding where the anatomy is, but the parotid gland looks like the thyroid or liver, so it's mid-level echoes. They should be nice and even mid-level grey, and this is my submandibular gland. So again, where the gland is marking out, imagine where your anatomy is, and you can kind of get your long and your trans. But often you can get stones within the glands, and you can see one here. There's a tiny little wobbly bit in this dilated salivary duct. And we've got some others. So, on this salivary gland, you can see that we haven't got that really even mid-level grey echo texture of the gland itself, and it's starting to be a little bit irregular, but you can also see quite prominent ducts. Now, if I turn the colour on, it shouldn't have colour flow in it. And obviously this one here, I don't know where the actual stone is, but as that problem gets bigger, you can sometimes see quite big stones with posterior acoustic shadowing behind it. So we just, again, look at the non-affected side, see what that looks like. That's your benchmark for normal, and then scan the affected side. So to summarise, we look at the area of interest, compare it with the unaffected side. We want to image in two planes, make sure that if there's any artifacts there, that the artifact is being generated by the pathology, or is it an artifact that is not something we need in the picture, or we've just caught it at the wrong angle. So if it's true pathology and there is an artifact, it should be like shadowing, it should be there in both planes. Think about using a standoff, whether that be gel, whether that be a water bath, or a glove filled with water, whatever, especially for stuff on the hands and when you need to see the actual skin surface. We want to be careful with how much probe pressure we're applying. We don't want to push too hard and sort of disperse the fluid, and also because it can be quite tender. And the big one here is to look for vascularity. Make sure you have your colour flow settings set quite low so that you can pick up low flow. Hold your hand quite still. Optimise your gain. So wind the gain up until it all flashes at you, and then just back it off until that just disappears. Then your gain settings should be set optimally for low flow in some of these vessels. So in some of these pathologies, I should say. When you've found that lump or bump, you need to understand its location. So if you can make reference to some sort of bony landmark, that's great. Look at the relationship to other surrounding anatomy, particularly any nearby arteries, nerves, veins, or, is it communicating with the joint, for example? What's the size of the pathology? What are the sonographic characteristics? Is it solid or liquid? Is it compressible or mobile? You'll notice with the lipomas, if you kind of push, they're like a little mouse, run away from you a little bit under the probe, and look at the questions. So, does anyone have any questions? So Rajesh was saying just yesterday he had a patient with a cat bite who had some punctums and erythema with swelling. Put the probe on to check for a collection and found cobblestone and picture of cellulitis. Just discharged within a couple of hours. Back home. Love POCUS. It's really cool. I think the potential for you guys to see more lumps and bumps than what we would ordinarily see in radiology is high, because we get the ones that are complicated and need sorting out, whereas I think it's possible to see lots of really interesting stuff.
think even more so in the rural regional areas, because then they don't get in to see their primary care doctor in a timely manner. So they end up coming to the ED more, where we have to deal with those problems, and like a cellulitis that's now become an abscess because it hasn't been treated. There was a very, I can't quote you the study, but I remember there was a really well appreciated study probably around, I don't know, 6, 7, 8 years ago now, which compared, had two groups. It had a group where the doctors were asked, so anyone was put in it that they thought had a cellulitic area, so a painful swollen red area. Now, obviously, if it was pointing pus, it was draining pus, those obvious ones, there's no role for ultrasound there. We know that it's an abscess, right? So it was anything that didn't have that. And then they said, okay, just do what you would normally do and we'll ultrasound them as well, but we're not going to tell you the results, right? And so what they found was that 70% of the patients that the doctor said was cellulitis correct, and they got antibiotics and they generally got better. But 30% of the time, the ones that the doctor said were cellulitis actually had an abscess and should have been incised and drained. On the other hand, 70% of the ones that the doctor said had an abscess, when they ultrasounded it, they didn't. So the poor patient got subjected to an incision and drainage when there was nothing there to drain, which was realized after they did the drainage. And so, you know, I think that study shows really clearly that these US doctors, and I'm sure Australians are the same, are not as good as they think they are in picking the cellulitis from the abscess. And it just goes to show you once again the fallibility of physical examination for anything. And that's why you need ultrasound. It improves your accuracy, clearly.
I think the key with the cellulitis versus abscess question is cellulitis is really quite superficial. So if you set your depth at, 3 or 4 centimeters, that's going to demonstrate that really nicely. But often you can have little tracks that go quite deep. So I tend to examine it first with quite a superficial setting to sort of get the detail of that, but then overdo the depth so that I can see, is there any deeper collections? Because a lot of the time you can have like cellulitis in conjunction with an abscess, and there'll be a track sort of going deeper to where the abscess is, and it doesn't necessarily correlate with where the patient says, my hand is sore here. I always get the patient, one finger point to where it's sore. And for abscesses, it doesn't always necessarily correlate like some other things can do, because the abscess can be sort of anywhere away from it. But yeah, make sure you first do it with a depth setting quite shallow, and you can see the cellulitis, but then do increase your depth, play with your gain settings to make sure that you're not sort of too bright and writing echoes in that don't exist, and you can potentially miss it.
Yeah, I think it's really important when you're calling an abscess or think you've got an abscess, you've got to be happy that you've found the entire limits of it. So, you can say that I've seen all the way around the abscess. And if I see an abscess where it's going deeper, like I can't see I can't see the deepest limit of it, it's going deeper than what my ultrasound can see, then I'm going to say that patient needs a CT scan. The ones that I won't do is infected wounds, like surgical wounds, because I'm always worried that things going deeper than I could possibly determine with the ultrasound. So I pretty much don't do those. I will do breast abscesses because in the rural regional area, otherwise you might not be able to get an ultrasound for them, and you can hopefully determine whether they need an intervention, or whether you can, if there's no abscess or it's a very small abscess, you can try antibiotics first, or switch your antibiotics around. But the other case I would mention, and I'm so kicking myself, I didn't take pictures of it, but it was so big. And again, this was a large patient. There wasn't going to be large patients who get the large abscesses. And he came in with this one that was sort of in the loin area. And I was thinking, oh, this is going to be a big subcutaneous sebaceous cyst, abscessy sort of thing, right? Infected sebaceous cyst. But it didn't look that big when you looked at it, because the man was a large patient, but it just went on and on and on, and it went to sort of the lateral extent to the flank, and it was at 23 centimeters wide at the back. And then I thought, this thing is massive. And you know what? It turned out to be, it was extending into his abdomen. So because it was so big, I said, we've got to get a CT on this guy and tell how far it's going. It actually turned out that it was actually coming from his abdomen, and it was actually it started as a psoas abscess in his psoas muscle. Wow. And possibly also diverticular abscess as well, because there was stuff around the bowel, there was stuff in the psoas muscle, and it actually extended posteriorly until it was visible in his loin. It was massive, absolutely massive. They ended up getting about 500 mils of pus out of this guy. It was massive.
Wow.
But I think you've got to be really certain that you've found all the limits of it. And if you're not confident on that, you definitely need to get a CT scan or some sort of second imaging as well.
It actually reminds me of a really good point there, Alan. I remember at one of the local hospitals, we were doing some coaching with a doctor, and there was a patient who very morbidly obese and had, they can't clean under their apron very well, and had oozing, disgusting smelling sort of mess all over the place. And, even as we were scanning, just us scanning, and I couldn't push very hard because she was so tender, but even just a little bit of pressure, just touching, was making more ooze. It reminds me of the need to make sure you put something on the probe. If you're scanning an abscess or anywhere where there's broken skin, use a probe cover. If you haven't got a probe cover, I have used Glad Wrap. That's not the best, but if you're just completely out of stuff, anything to protect the probe and keep your probe clean, you're then going to have to do proper high-level disinfection of your probe afterwards. But it's useful to bear in mind that you need some sterile gel, and anywhere where the skin is broken, sterile gel. If you haven't got sterile gel, anything that's wet, you just need to be able to have the probe slip on the skin without causing too much irritation, and enough water to transmit this out. So you can use some saline or some Chlorhex, whatever, to wet the skin, but make sure you use a probe cover, and then make sure that you are doing high-level disinfection of your probe afterwards.
Yeah, you definitely don't want to spread some nasty like MRSA or something to other patients. Yeah. Other thing I was going to say about that cobblestoning is that you do see it actually in people with peripheral leg edema from other causes like heart failure. But I'm assuming you don't get the increased echogenicity of the tissues, but you certainly get the cobblestoning. So you've got to be a little bit retrospect when you see the cobblestoning. You can't always assume that that's due to cellulitis, because there are any fluid in those legs, any edema will cause that cobblestoning appearance. So, but yeah, I'm assuming you probably don't get the increased echogenicity because you don't have that actual acute inflammation in the tissue.
In the first instance, you get, even on patients, post-surgery or whatever, or they've been in the bed for ages, or your heart patients, the increased fluid in the tissue at first is quite bright. And so you'll notice it on, like patients for a DVT study, and they've just got really edematous legs. Often the tissue is quite bright, and it's because there's more, the fluid in the tissue gives you more interfaces and more bouncing of the sound. And so the ability to get, even on a regular linear probe, to get on a larger patient, even just getting their veins can be quite hampered because of all the fluid in the tissue. So you need to use a curved probe for those patients just to get enough penetration. But
so basically, if you've got a patient who's got, heart failure and then they get cellulitis, it's going to be hard with an ultrasound to tell, well, is this just their heart failure causing this appearance, or is it cellulitis? But that's okay, because if we're not certain, we're going to err on the side of giving them antibiotics. I think the important role is more the differentiating the cellulitis from the abscess, isn't it? Because that's going to clearly significantly change your treatment. And the worst thing, as I said, is that I would feel very guilty about is sticking scalpels into people and then for no result and no benefit.
Yeah. Or sticking a scalpel into someone that has a vascular mass. You don't want to do that either.
There's been some case reports of of, isn't it? Like pseudo aneurysms being incised and then blood going everywhere.
Yeah. And again, I guess the clinical history is really important then too. You know, is it an infection kind of history, or is it after an aneurysm and there's big pseudo aneurysm? Because that'll look quite different.
Hey,
So did anyone else?
Oh, yeah.
Rajesh.
Yeah, hi. Look, no, I was saying, I mean, yesterday was my actual POCUS day for abscesses, in fact, because in the morning I had this cat bite one, and then later on I had a young girl who had recurrent abscesses in a groin and all, like an axilla, and she's coming really bad. They're so lumpy and fluctuant and all, and it's like 5 p.m. and there's no way you're going to get a formal one. And the disposition actually changes like dramatically, because I did a bedside ultrasound, and I've shown demonstrated collections, deep collections, which need a surgical IND and a general anesthetic. So I can convince the surgical team, inpatient surgical team, and look, we started antibiotics, we've admitted them easily, they've consented, fasted and all that stuff. So it makes such a big difference. I mean, otherwise, poor patients just waiting endlessly for a formal one because no one's really sort of sure and all that stuff. So, I mean, really makes a big difference, as I said.
Yeah.
And sometimes, Rajesh, the other thing that happens is, and you know, the surgeons, like most inpatient doctors, if they can handball or delay, they're not disinclined to do that, is that sometimes you think clinically it looks like it's a fairly small abscess, and you're thinking, yeah, look, probably I could consider having a go under local in the ED if that patient will tolerate it. But then you put the ultrasound on and you're surprised that it's a little bit more extensive than what you could appreciate from the surface. And then, as you say, then you can have a more accurate conversation with the surgical doctors and say, look, sorry, this one really isn't for us.
Mm-hmm.
Yeah, and I actually, that's very important, because I keep telling the trainees, I mean, just don't start sticking in stuff. I mean, you're doing a POCUS for a reason to sort of not only quantify, but qualify as well, rather than just, oh, let's do it in ED and jump in, because it all, as you said, the depth and the extent and all that, because it comes back to primary care as well. Sometimes we get patients from primary care who have had needles stuck in, but they've represented because their collection has gone worse. It's all because they're deep and they've never been probed properly, because they need decent dissection and sort of cutting. There's probably loculations and all that stuff. So it's so much important to sort of just not rush into things and just qualify it more when ultrasound is how it's going to be like.
Yeah, and as Suean was saying, the other thing that's really useful is telling how thick the fluid is, because you can sometimes see quite well why it is that the GP failed to get anything out when they stuck a needle in it, because it was too thick to suck anything out. And generally that's the case most of the time. I've had 1 or 2 patients where I've looked at the fluid and I thought, this is really thin fluid. The other one that we didn't mention is seromas as well you get. I generally speak to the surgical doctors about them because they're usually known or pre-existing from previous surgery, like in the axilla and stuff like that. But sometimes you get an abscess with really thin looking fluid in it, no particulate matter. And you think, oh, look, it's at least worth a go rather than incising straight off to put a decent sized needle in. And a couple of times I've done that and got a good result. But on the other hand, when you look at it, most of the time you go, oh, this stuff has got thickish stuff in it. There's no way you're going to be able to clean this out. Or the other thing, as Suean showed in the pictures, is it's got multiple septations in it. And unless you break down all those septations with a really good probing and incision, you're never going to get that stuff out just with a needle.
Yeah. Well, thanks you all for coming tonight. And if anyone has any ideas for what they would like to see on next time's Coaching Corner, either speak up or get in touch either on my email or via Twitter, however, and let me know if there's a particular topic you want to chat about.
Thanks, everyone. Thank you, Suean.
Thanks, Suean.
Thanks so much,
Thanks,
everyone.
Suean.
Bye.
Alrighty. We'll see you next time.